This is our Neuro Eye Disease project on Alzheimer's disease and the visual system. November is National Alzheimer's Month, so we're going to share on this disease that changes the lives of millions of Americans each year.
Alzheimer's disease represents a biological disorder with psychological manifestations in which the highest levels of thought and action are affected. On autopsy, the Alzheimer's disease brain shows dense formations of neurofibrillary tangles and plaques in specific cortical and subcortical areas. Although many plausible genetic, viral, and toxic hypotheses have been proposed, the etiology of Alzheimer's disease is currently unknown.
So just going over some of the American statistics, Alzheimer's currently stands as the 6th leading cause of death in America. Every 66 seconds, someone develops this life-changing disease. 1/3 seniors die of Alzheimer's or from another type of dementia. Currently, 5 million people are affected, and that number is increasing due to an increase in aging population. 10% people 65 years or older have Alzheimer's, and 2/3 people with Alzheimer's are women. As far as demographics, according to the Medicare reports, the highest number of diseased patients are in the South and East areas. This mostly corresponds with population in those states, but these areas are also areas with higher incidences of poor health conditions. Regardless of state, these numbers will all rise significantly with the increasing aging population. Although the etiology is unknown, some possible causes and risks that we may know are we have genetic mutations where less than 1% develop due to a mutation in the gene for the amyloid precursor protein. Those presenting with the mutation have a 95% chance to develop the disease. There's also a link with Down syndrome. People with Down syndrome are at higher risk for developing a form of Alzheimer's disease. Although scientists are not certain why, it may be related to the additional copy of chromosome 21. Some of the risks are, first is age. The greatest of all, this is the greatest of all risks. While younger patients can still get Alzheimer's, they're much less likely. Family history, although it is not necessary to develop the disease, first-degree relatives put you at a higher risk. Then there's the apolipoprotein E4 gene. Everyone inherits one of these 3 forms of APO. One variant increases your chances of developing Alzheimer's, especially if a mutation is involved. Education. People with fewer years of formal education are at a higher risk. People with more years of education increase connections between neurons in the brain, which allows for compensations. And last is TBI, a disruption of normal brain function due to trauma. When someone is unconscious for more than 24 hours, it is considered severe. People with severe to moderate TBIs are at higher risk for Alzheimer's.
In Alzheimer's disease, the cortex of the brain shrivels up over time. The hippocampus is a specific area of the cortex that plays a key role in new memories, and it's known to be affected first. Ventricles, located here, contain cerebrospinal fluid, and in Alzheimer's, they get larger over time due to the decrease in size of the cortex. In Alzheimer's disease, brain changes may occur up to 20 years before diagnosis. In general, brain tissue in Alzheimer's disease has many fewer nerve cells and synapses than a healthy brain. Current studies include determining what is healthy brain tissue in the aging population to have a direct comparison to the differences noted in the same age person with Alzheimer's disease. There are 2 major findings in a brain with Alzheimer's disease. Plaques are one of them. Plaques consist of beta amyloid proteins that are sticky chemically. They form from larger proteins found in fatty membrane that surrounds the nerve cells, and over time clump together to form the plaques. There are thoughts currently that smaller plaques are worse than larger clumps. This is due to small clumps blocking cell-to-cell signaling at the synapses. They may also activate an immune response resulting in inflammation. Tangles are the dead and dying nerve cells made up of twisted strands of another protein called tau proteins. Tau proteins help the tracks, known as microtubules, stay straight. The tracks are a transport system organized in parallel strands that transport food molecules, cell parts, and other key materials. When the tau proteins break down, the tracks fall apart and disintegrate. Nutrients can no longer travel to necessary cells, and those cells then die. This illustration represents both amyloid plaques and tangles. The color differences represent the severity, green being less severe and red being most severe, along with the locations in the brain that they are located.
So just going over some of the stages of Alzheimer's, in the mild stage, the person is usually still driving and may be a part of social activities as they always have done. They may notice they are starting to have more forgetfulness with common words and location of objects. Friends and family may notice these difficulties with the individual as well. They tend to begin to misplace valuable objects and have noticeably difficulty with planning and organizing events and their own personal schedule. They are still independent in this stage, including paying their own bills. In the moderate stage, it's typically the longest and can last many years. More behavioral changes are noted in this stage, such as an increase in frustration and anger. Symptoms will certainly be noticeable to others in this stage. A person in this stage may experience the inability to recall old addresses or the schools they have graduated from in the past. Confusion about the date and time and about proper clothing for a particular season may be evident. There are also changes in sleep patterns such as restlessness at night and sleeping during the day. Significant details are usually still remembered, but a person in this stage still needs help with activities of daily living, such as paying bills, making doctor appointments, and helping determine proper clothing for the weather. In the severe stage, communicating becomes extremely difficult, especially communicating pain. Their response to the environment is lost eventually, along with the ability to carry on a conversation, and lastly, their ability to control their movement. They will need round-the-clock assistance for activities of daily living. There is also a notable increase in risk of infections, especially pneumonia. The colors in the images to the right represent the location on the progression of the disease.
Currently, there is no cure for Alzheimer's disease. Any independence that can be maintained early along in the disease as well as social interactions and activities are important. Physical activity is also a very important aspect to continue while the patient can be involved. Follow-up exams every 3 to 6 months is recommended unless there are comorbidities also being managed that indicate being seen more frequently. Monitoring the caregiver's stress levels, stamina, and health is also important throughout the management of Alzheimer's disease for a patient. Education is probably the most important aspect of this disease management currently. In early stages of the disease, education to the patient and family regarding prognosis and disease progression is key. Also involve patients and family in treatment goals specific to patient's current stage of the disease. Education regarding safety hazards as the disease progresses is imperative. This includes firearms, driving, operation of tools and kitchen appliances, and handling household poisons and cleaners. Education on the risk of wandering as disease progresses and risk of falls and perception and balance issues is important as well. Non-medical issues need to be addressed also. This includes a living will, resources for ongoing support, finance reviews, power of attorney for health care, planning for care needs as the disease progresses, and end-of-life care. These are issues that are difficult no matter the stage, but tend to be easier if determined earlier on in the disease process, especially if the patient can be involved in these decisions. No management strategy is set in stone. As the disease progresses and family situations change, there could be need to alter the management plan. Giving resources to patients and families is also so important. One important resource is www.alz.org, a website dedicated to information on the disease with resources within to help. There are message boards for those with the disease as well as family, friends, and caregivers. There are support group locators, list of professionals, and information about research. You'll even find ways to join the cause. There is also a hotline available 24/7.
The majority of Alzheimer's patients present with symptoms of visual agnosia, visual neglect, and occasionally visual hallucinations, but there are other signs that can potentially be seen in the eye to suggest Alzheimer's disease. Visual system abnormalities in Alzheimer's were recognized in the early 1970s, but were initially considered to be of strict cortical origin. Studies over the past 20 years reveal that all parts of the visual system may be affected, including the optic nerve in the retina. Studies have suggested a 25% decrease in the number of ganglion cells and an 82% increase in the ratio of astrocytes to neurons in the retina. The studies used for these statistics involve a relatively small number of eyes, so it is difficult to determine if this correlation is consistent among all Alzheimer's patients. A recent study found that AB plaques in the retina of 5 patients with definite Alzheimer's disease in the retina of 5 suspect Alzheimer's patients, and they did not find them in 5 age-matched normal controls. Unfortunately, the procedure to detect AB plaques in the retina is fairly invasive and involves removing the vitreous and use of high-resolution optical imaging. Macular thinning is another area of interest in ocular associations with Alzheimer's. One study reported that, on average, the total macular volume was decreased in 14 patients with Alzheimer's disease compared with 15 age-matched control subjects. The superior colliculus receives about 10% of the retinal ganglion cell axons and is involved in the control of eye movements. Numerous amyloid plaques have been found in the superior colliculus of Alzheimer's patients. Furthermore, subsequent studies identified plentiful neurofibrillary tangles as well. These changes in the superior colliculus may explain the ocular motility problems often encountered in Alzheimer's disease. Damage to the primary visual cortex in Alzheimer's patients has also been noted. Plaque neurofibrillary tangle accumulation, decreased neuron numbers, decreased capillary density, and decreased level of certain enzymes in V1 have all been documented upon autopsy in Alzheimer's patients. Recent studies suggest that early and late onset forms of the disease may have different patterns of cortical impairment, with the early onset forms presenting with more gray matter loss in the neocortex and the occipital lobe, including the secondary visual cortex, however sparing the primary visual cortex, while the late onset form involving more diffuse gray matter loss and more pronounced in the hippocampal area. Studying attention can be an effective way to detect early signs of the disease, since attention deficits are often found prior to any language impairments in people who have Alzheimer's disease. Evidence has pointed to impairments in selective visual attention, which is the ability to focus on a target stimulus while filtering out distractions, in early stages of Alzheimer's disease. This worsens linearly with disease severity. In a study composed of simple and conjoined feature search tasks, the level of attentional functioning in patients with varying degrees of severity of Alzheimer's was evaluated and compared against a control group. It was found that Alzheimer's disease patients had significant deficits in visual attention, as revealed by their slowed target detection speed on the conjoined feature task, as shown in this chart here. Optic nerve pallor and increased cup-to-disc ratio are both common in patients with Alzheimer's, however, are not found amongst all Alzheimer's patients, and are also found with other conditions. So while it is important to relay the correlation of these findings with our Alzheimer's patients who present with them, it is not likely to be the sole contributor to the diagnosis. Use of an OCT can be helpful in demonstrating regional and sometimes global thinning of the retinal nerve fiber layer in Alzheimer's patients. The recent introduction of spectral domain OCT with improved axial resolution to below 5 microns may provide the basis of more detailed analysis of different retinal layers and could reveal abnormalities undetectable by the previous generations of instruments. Contrast sensitivity evaluation is an easy method to support a diagnosis of Alzheimer's disease. The majority of published studies regarding contrast sensitivity in Alzheimer's find that the contrast sensitivity function to be affected in patients with Alzheimer's. Some recent work demonstrates that the deficit in contrast sensitivity in Alzheimer's patients accounts for most of the differences in performance on letter identification, word reading, picture naming, and face discrimination. The image shown on this slide comes from a study that found significant higher CS thresholds for Alzheimer's patients in comparison to elderly controls. VEPs are not as easily accessible as evaluating contrast sensitivity, however, can be a helpful tool as well. Numerous studies looking at VEP results in Alzheimer's patients found a significant delay in the P2 and other peaks in the flash VEP in Alzheimer's patients when compared against age-matched controls. Some reported also reduced amplitude and missing peaks. EEG is another electrodiagnostic tool that can be helpful in differentiating a diagnosis of Alzheimer's with dementia with Lewy bodies. Dementia with Lewy bodies is the second most common cause of dementia. Studies have suggested that EEG abnormalities are more severe in patients with dementia with Lewy bodies when compared against Alzheimer's patients, reflecting the more severe loss of acetylcholine.
In the past few years, the Alzheimer's disease research enterprise has developed improved techniques and technologies aimed at early diagnosis and detection of Alzheimer's disease. The field has seen remarkable growth in research using clinical assessment, psychometric testing, cerebrospinal fluid-based biomarkers, magnetic resonance imaging, measurements of brain volume, and molecular imaging of beta amyloid in the brain to diagnose Alzheimer's at its earliest stages. Before these and other diagnostic measures can be incorporated into clinical practice worldwide, they must be standardized and validated on a global scale. The Global Consortium for Biomarker Standardization brings together these experts in teleconference and face-to-face meetings to address the challenges inherent in this goal and to develop the global scales required for worldwide implementation. Currently, there are 5 FDA-approved Alzheimer's drugs that temporarily help memory and thinking problems, but these medications do not treat the underlying cause of Alzheimer's. Researchers are developing medications aimed at almost every point in amyloid processing. Aducanumab is a recombinant monoclonal antibody targeting aggregated forms of beta amyloid that help develop into amyloid plaque in the brains of people with Alzheimer's disease. AADVAC1 is a vaccine that stimulates the body's immune system to attack an abnormal form of tau protein that destabilizes the structure of neurons. If successful, it has the potential to help stop the progression of Alzheimer's disease. Other targets are more areas involved in the process of amyloid production.
If you would like more information on caregiving resources or you would like to donate to help support future research, please visit the following websites.
The following references were used in support of our presentation.